Hello everyone. So this will be the part 2 of RAAS inhibitors, and this will mainly be about ARBs, the third type of RAAS inhibitor. So 81 receptor blockers are known as ARBs. So angiotensin 1 receptor blockers mainly end in the word sartan, and the angiotensin receptors work on all the GPCR, all the G protein coupled receptors. They are all GPCRs. So there are four types of angiotensin receptors: 81 or the GQ type, and A2 and AT3 type, which is the GI type, and the 84 type, which is found in neurons. So the GQ type, which is responsible for increase in BP. 82, 83, the GI type is responsible for decreasing BP, and 84, which is found in neurons, is responsible for memory and cognition. So that is why 81, it is 81 receptor blockers, because we want to block the GQ type, which is responsible for increase in BP. So what are the drugs in the 81 receptor blockers? So the drugs can be remembered by the mnemonic love, tick. So love is the mnemonic for losartan, which has the lowest affinity for the 81 receptor. O is olmesartan, V is valsartan, E is eprosartan, T is telmisartan, I is irbesartan, and C is candesartan. There is a new drug in this, that is azilsartan, but we'll talk about it later. So as I said, losartan has the lowest affinity for the 81 receptors, and in this the route of administration is orally for the ARBs, and they are not used in emergencies, because in emergency you want fast action, and orally it is not fast, like the action is not really fast. Okay, and this is not given as IV or IM or in any injection form. So yeah, not used in emergency. The most potent ARB is candesartan, and the least potent is losartan. And the longest acting is also candesartan first, then there is olmesartan, and the shortest acting ARB is eprosartan. Candesartan is the longest acting and the most potent because it binds with the 81 receptor with the highest affinity, while losartan has the least affinity. All the sartans are competitive blockers of the receptors, and all of the sartans are excreted in the urine and also the bile, except telmisartan. Telmisartan is only excreted in the bile and not in the urine. So that is why telmisartan is safe in renal diseases and renal failure. So what are the advantages of angiotensin 1 receptor blocker over ACE inhibitors? So ARBs do not increase the level of bradykinin, but with ACE inhibitors we saw that the levels of bradykinin are increased, which causes symptoms like daru, and the two of the most common symptoms are dry cough and angioedema. What are the special properties of ARBs or sartans? So let's see. For losartan, the special property is it has an antiplatelet effect because it blocks thromboxane A2 receptors, and it also has a uricosuric action, which is good for gout patients. So uricosuric actions mean there is an increase in uric acid excretion. Irbesartan, the irbesartan special property is it is effective in atrial fibrillation because it blocks SA node of the heart. So it is effective in atrial fibrillation as it blocks SA node on the heart. There will be a reset of the rhythm. And in telmisartan, it has a PPAR gamma agonist property, which is like anti-diabetic medication, which is called pioglitazone. So what is PPAR gamma? PPAR gamma means peroxisomal proliferation activity receptor, PPAR gamma. So it has an insulin sensitivity or action improves, and it reduces the risk of type 2 diabetes mellitus. So it also has a special property of acting like an anti-diabetic medication, which is pioglitazone, or oral hypoglycemic agent pioglitazone. So what is the side effect of sartans? So sartans can cause sprue. And what is sprue? Sprue is diarrhea, which is caused by malabsorption, and there will be weight loss. So the maximum risk of sprue is in olmesartan. So how sprue happens? So the AT1 receptors are blocked, so the level of angiotensin which increases act on the AT2 receptors, which reduce or inhibit the absorption of food, which can cause malabsorption or diarrhea in the patient. And the maximum risk of sprue is by olmesartan, as I just said. So this was just a small part of the RAAS inhibitors that was left. This was part 2, and next we'll cover another set of medications. This is just for private use, but if anyone finds it helpful, I'll be thankful for that. So I'll just end it now.